Amit Gupta sir for giving me this opportunity to present this small topic on dietary protein in pre-dialysis patient. Respected seniors, my teachers, what I would like to say in this presentation spanning over the next 20 minutes is that I would like to give the basic concepts rather than going to the nitty-gritties of each trials which were done in this field of pre-dialysis patients. So as we all know, this is the heat map of chronic kidney disease, in which we have division of the stages of CKD into G1, G2, G3, G4, and G5 based on the glomerular filtration rate. Again, this is an estimated glomerular filtration rate in which we try to estimate the glomerular filtration rate from a compound like creatinine or cystatin C. This will have an implication on our patients' GFR, because here we are trying to use creatinine as a measure of the GFR. So when we are dealing with a nutrition topic, we need to be clear that the creatinine by itself can be higher in a patient who has got more muscle mass, and a creatinine may be relatively low in a patient who is having wasting, and that might actually indulge in the estimation of the glomerular filtration rate. On the other side, we know we have the A classification based on the proteinuria into A1 and A2 and A3. And based on this estimated GFR and the proteinuria, we can classify the patient whether they have a high risk of progressing into end-stage renal disease or CKD stage 5D or not. So the normal loss of GFR is about 0.75 to 1 ml per year after the age of 40 years. And as the age progresses, we have a normal decrease in GFR. Similarly, based on the disease particular of different chronic kidney disease, be a proteinuric illness, be it an interstitial disease, or it's a diabetic nephropathy, the rate of loss of GFR is different in different people. So as far as we are concerned, the diabetic kidney disease being one of the most common cause of chronic kidney disease all over the world, especially in India, we find that the decline is as high as 10 ml per minute per year. And what we are concerned is, as we don't have a curative weapon in our armamentarium as far as CKD is concerned, our main target is to retard the progression of CKD, and that is the important strategy as far as all chronic kidney disease is concerned, so that we sort of try to maintain the GFR for a longer period of time and hence delay the dialysis to the extent what is possible. So what are the strategies to retard the progression of CKD? So we all know that level 1 recommendations, we have the control of blood pressure, which is far important, diabetic control, renin, angiotensin, aldosterone system blockade. And as time went by, and we have one wonderful medicine involving the SGLT2 inhibitors, which have changed. We have changed the scene for chronic kidney disease and patients who have cardiovascular morbidity. And as far as we are concerned, the dietary protein restriction is one of the very important level 1 recommendation as far as retarding the progression of CKD is concerned. The level 2 recommendations, we all know: salt restriction, decreasing the components of metabolic syndrome, smoking cessation, control of serum phosphorus, alkali therapy, and minimizing the nephrotoxic drugs. So what all we do know till now? So we know that a high protein load will increase the glomerular filtration rate, and it can result in kidney injury being worsened. Most of the studies have been done in pre-population, that means on laboratory benches, in which they've studied rat models in which an increased protein intake was associated with increased glomerular sclerosis and proteinuria. They also found out that a decreasing in the protein has resulted in the decrease in the glomerular filtration rate, and these benefits of decreasing the protein in the diet has resulted in a decrease in the decline in GFR, and this benefit was seen throughout the wide range of GFR. And they also found out the high protein intake. If an animal had taken a higher protein intake, there was an upregulation of the pro-inflammatory genes, which probably could explain why the CKD is progressing in addition to the hyperfiltration theory. And this physiology of the above findings were all elucidated in animal studies. And then subsequently further trials were done to find out whether this can be extrapolated to populations of patients who are having chronic kidney disease at different stages. So let us come to basics of some physiology and how does this low protein diet act. So we have a glomerulus here, we have the capillary loop, then we have the Bowman's capsule, and here we have the afferent arteriole, which brings blood through the glomerular capillary, and we have the efferent arteriole, which goes down. So as we all know, it's basically the relative constriction and the vasodilatation of the afferent and the efferent arteriole, which actually determines the glomerular filtration rate. So if they have a vasoconstriction at the efferent arteriole and vasodilatation at the afferent arteriole, the glomerular filtration pressure within the capillaries will be high, resulting in an increase in intraglomerular pressure and increased filtration. At the same time, we have a vasoconstriction of the afferent arteriole. There is a decrease in the blood coming to the capillaries, and hence there is a decrease in the intraglomerular pressure. So the low protein diet, ideally what it does is by chemical mediating the vasoconstriction of the afferent arteriole and hence decreasing the blood coming to the glomerular capillaries and decreasing the glomerular filtration rate. So what extra advantage do we have? Because we have a lot of drugs like our AC inhibitors, ARB blockers, which actually acts at the afferent arterioles. So these are the drugs which will bring about vasodilatation of the efferent arteriole. So that means to say that when we have a patient who has got some proteinuria and glomerular hyperfiltration, we block the efferent arteriolar vasoconstriction by giving an AC inhibitor or an ARB blocker. And in addition to that, with significant amount of low sodium diet, we're actually bringing about afferent arterial vasoconstriction and efferent arterial vasodilatation, resulting in a decrease in the intraglomerular pressure and a decrease in the glomerular filtration rate. Is that all? No. We have additional mechanism in which it has been found out that the low protein diet also brings about decrease in the mesangial signaling, decrease in the transforming growth factor beta signaling, resulting in a decrease in interstitial fibrosis. So the benefits of all put together, what we see is that it is more than what each of these individual measures would act. That is what is called a synergistic effects of AC inhibitors, ARB blockers, and as well as low protein diet is concerned. So this diagram might look a little complicated, but it's not that complicated. Let's go to each and everything. So this is something which happens in our normal body. We have the gut, which has microbiota, a lot of bacteria. And when we take a normal diet, we have the microbiota acting on it. We have the enzymes acting on our proteins, breaking them into amino acids. And the amino acids, like tyrosine, gets converted to paracresol and indole. And these are taken up into the liver. And in the liver, we have this these are converted to uremic toxins, and then it is circulating in the blood. At the same time, we have ammonia, which is synthesized in the kidney, which comes into the liver. And in the liver, we have the amino acids which are coming to the blood to the liver. And the amino acids here can undergo deamination, resulting in ammonia as well as glutamate and alpha keto acids. And this alpha keto acid normally is either used for further generation of amino acids, or it can be taken in the TCA cycle. So we know the ammonia is produced because of the amino acid metabolism, and the ammonia normally gets converted to ammonium and then can be secreted in the urine, or else it also can be, since it is very volatile and is a toxic substance, it can be taken up by the urea cycle to get converted to something which is less toxic, and that is urea. So we know that when we have renal dysfunction, we have high concentration of urea, and they're here because of the high concentration of the urea. This urea, further by certain mechanism, will result in an increase in the reactive oxygen species, endothelial dysfunction, in addition to the uremic toxins like paracresol sulfate and indoxyl sulfate, which again cause endothelial dysfunction and hence resulting in increase in the cardiovascular events. So we have a CKD patient who has this physiology there, and at the same time, if we have a decrease in the protein diet, that will result in the decrease in the amino acids, and hence these decrease in the amino acid further will result in the decrease in the number of ammonia production as well as in urea production, as well as at the level of the gut, there is decreased amount of paracresol sulfate and indoxyl sulfate, and hence decrease in the uremic toxins, and the endothelial dysfunction will not happen as much as what it would have been done with a normal protein diet. A less phosphorus in the decreased protein diet again will result in a decreased phosphorus in the blood, will also prevent the osteodystrophy from happening, and hence decreased vascular calcifications, etc., and then again will bring about the decrease in the cardiovascular events. So this is basically a decrease in the protein diet will cause a decrease in the urea production. It also decreases the reactive oxygen species, decrease in the toxic middle molecules, which most of the time we are not able to measure. And it also brings about a decrease in the phosphorus content. So how is it? It's like a multi-pronged approach in as far as when you're dealing with a low protein diet is concerned. So if you look at it, these are the benefits. So nothing comes for free. When you have a benefit, there's an accompanying challenge which comes along with it. So we all saw that the proteinuria, the decreased protein intake will result in decrease in the CKD progression by bringing down the glomerular hyperfiltration. And what we found out that the afferent arteriole constricts, decreasing in the glomerular filtration rate. So when we start a patient in a low protein diet, it's possible that in the initial phase, there is a transient decrease in GFR. This was actually even seen in the MDRD trial for the initial few months, in which there was a decrease in GFR plot in the patient who were taken on low protein diet. So that could be something which is a transient thing. And further, when we continue the low protein diet, it's very much seen that the sort of the slope sort of stabilizes and overtakes the high protein or the usual protein diet. It results in decrease in the proteinuria by an anti-proteinuric effect, which acts predominantly on the glomerular filtration rate. But what we found out in a proteinuric patients, we have a tendency that we try to sort of supplement further protein intake. So it's contrary to the notion that in a proteinuric patient to bring up about albumin, serum albumin, we'll have to supplement more protein. So low protein diet by itself, by decreasing the proteinuria, can help in bringing up the serum albumin and the protein levels of that particular patient. We also found out that the urea levels are brought down, and probably we are able to defer dialysis. And many trials have consistently showed that we are able to, by instituting low protein diet, we are able to sort of prolong the dialysis initiation. And what the risk involved here is that since already when you have a patient who's got CKD stage 5, he is already sort of having decreased appetite, etc. And that when added to a low protein diet, when it's instituted unscientifically and without monitoring, it can actually exacerbate an underlying protein energy malnutrition or a protein energy wasting, and can be worse for the patient. The metabolic acidosis part is also decreased with the low protein diet, because, and more so when we have a low protein plant-based diet. We also saw that the phosphorus absorption is less with low protein diet, and hence it can result in decrease in the metabolic bone disease. But the problem here is that when you use very low protein diet along with alpha keto analogs, sometimes the alpha keto analog comes with a combination of calcium, and the calcium load can increase in such patients. We also found out that the low protein diet is associated with other cardiovascular benefits because of a decrease in salt intake. Because when you try to reduce the low protein, there's also an associated low salt and low saturated fat intake, which can give us further cardiovascular benefits. There's an increased betterment of blood pressure control also with low protein diet. So how low is low? So just go back to the history. If we have something called the MDRD trial, which was again divided into MDRD1 and MDRD2. There was a modification of diet in renal disease 1 and 2. There's a number of patients in MDRD was on about 585. They took patients who had GFR of 25 to 55. As far as MDRD2 was concerned, it was around 255 and the GFR was less. That means it was around 13 to 24 in MDRD2. And what they did in MDRD1 was they compared a usual protein intake, that is about 1.3 gram per kilogram per day, versus low protein, that is 0.58 milligram per kilogram. So they try to compare a usual protein intake in a Western diet, which is around 1.3, versus low protein, which is around 0.6. And in MDRD2, what they try to compare is, they try to compare a low protein diet with a very low protein diet along with alpha keto analog if they had used very low protein diet. So what they found in MDRD1 is that they, in short term, they didn't find much benefit because the follow-up time was not great. It's about 36 months. And then they try to extrapolate this short-term follow-up with registry data, which was followed a period for about 12 years. And what they found is long-term, they had some benefit at the end of 6 years when low protein diet fared better with respect to the decrease in GFR. But when they followed up the patient for another 6 years, the benefit was gone. Probably because for the next 6 years, the patient had deviated from their dietary restrictions or so. And in MDRD2, what they found out was by giving very low protein diet, it neither did not delay the progression. I mean, it did not delay the progression of CKD, and in fact, a very low protein diet resulted in increased risk of death. There are multiple points against the methodology of the study, in the sense that it was a short follow-up, the populations are small, and patients who are predominantly diabetic were not so high in this group, and patients who were on insulin were actually excluded. So a potential group of people who would have benefited from this trial were sort of taken back, and they were not so much included in the study. That might skew the results. So, but is that the end of it? No. A lot of trials subsequently came in addition to the MDRD, and they tried to do a lot of meta-analysis, including all this study. And in this forest plot, what you see is that most of these lines are tending towards the right side and not even touching the central line. And the diamond plot, if it had been here, it's actually favoring in the line of a low protein diet. And the meta-analysis, which actually included the MDRD trials, again favored a low protein diet. And what they found was that there was a benefit in low protein diet in multiple trials. And a lesser benefits was seen in diabetic patients. And there was also associated benefits of hypertension, metabolic bone disease, and acidosis when a low protein diet was concerned. So that is not the old story. So now what is it about that KDOK has to tell? We have the Kidney Disease Outcomes Quality Initiative. They have come with the guidelines in 2020. And what does it have to say for us? Here they have classified the patients in CKD states 3 to 5 into non-diabetic and diabetic. As far as non-diabetic is concerned, the recommendation grading is about 2C, and as concerned with the diabetic, it's just an opinion. And CKD stage 3 to 5 in non-diabetic patients, they have divided in the either patient can be given a low protein diet that is about 0.5 to 0.6 gram per kilogram per day. And if it's a very low protein diet, it can be given as 0.2 to 0.4 gram per kilogram per day, along with an alpha keto analog. So here, what they're trying to find out, they're trying to limit the protein intake further. But when you limit the protein intake to that extent, there is a very high chance that essential amino acids are missed, and the patient will have a chance of going into protein energy wasting. And hence they added alpha keto analog to it. So what is how many number of tablets do we add of alpha keto analog? So again, this also is given in the recommendations, in which if you're trying to give a protein restriction to the tune of 0.3 to 0.4 gram per kilogram, we give about 1 tab of keto analog for every 5 kgs. And if you give a little more higher protein, 0.4 to 0.5 gram, sorry, it's not milligram, it's gram per kilogram, we give about 1 tab for every 10 kgs. And as far as diabetic is concerned, we give around 0.6 to 0.8 gram per kilogram per day is the opinion recommendation. So when we speak about the low protein diet, it is important that we need to know what is the actual recommended dietary protein allowance for a healthy human. And what do you mean by RDA? The recommended dietary allowance is the level of nutrients intake to meet the energy needs of a practically all healthy persons. And for an RDA of a protein for a sedentary healthy being, human is about 0.8 gram per kilogram. So that is the normal, what is the recommended dietary allowance. And when we do a low protein diet, you try to give about 0.5 to 0.6, and a very low protein diet, you give around 0.3 to 0.4. And an average Western diet has a protein intake of about 1.3 gram per kilogram. So that is something which we normally eat probably in a Western diet, not so much maybe for an Indian diet. And when you speak about protein, we also need to understand the concept of the biological value of protein. So what do you mean by the biological value of protein? It is the proportion of the absorbed protein which gets incorporated in the organism's body. So whatever it's absorbed, what percentage or what proportion does it get incorporated in the body? That sort of defines the quality of the protein, in the sense that it gives a protein which has got a high biological value, will have a lot of essential amino acids. So when you are restricting the protein, it's also very important that we give a high biological value protein, so that it is sort of used in protein synthesis in our body. So when we have these kind of recommendations, so what is more important is that this recommendation clearly tells where it should not be used, or where it should be with caution. So when we have they say that these guidelines have to be used only in metabolically stable patients. That means to say that the person whom you are trying to implement this guideline-based protein restriction should be having no active inflammatory disease, should not have any underlying infective disease. You should ask for history of any hospitalization in the last 2 weeks, because this hospitalization and acute disease might push the patient into a catabolic state, which is not stable, and these stages might actually require more protein than actually restricting it. So absence of a poorly controlled diabetes a significant short-term loss of body weight, an absence of an presence of an antibiotic or an immunosuppressive regimen which was given, all this can push the patient to sort of a unstable state in which the patient might be actually requiring more of a protein supplementation than a protein restriction. So these are all red flag signs which we have to be very careful when you are actually restricting the protein intake. So in this guidelines, they've classified by telling us if you do protein restriction alone, what are the benefits? And if you do a protein restriction along, then the tune of a very low protein diet along with alpha keto analogs, what are its implication on the state survival, renal survival, the decrease in the GFR, phosphates, blood pressure, nutritional status, lipid profile, etc. And what they found is that when you use protein restriction along, that is a low protein diet, they have beneficial effects on survival and end-stage disease. We are actually able to push the dialysis longer. And all this, each individual analysis is based on multiple trials. And a lot of trials have different interpretation in the sense that some trials show that there is a benefit with respect to prolonging the renal survival. Some studies have shown less of, not so much benefit. So what they try to find out in most of this is that they try to pool all the studies and try to give a pooled interpretation in whichever scenario where they could. And they sort of come to a conclusion that, yeah, this is sort of beneficial as far as renal survival is concerned or quality of life is concerned and things like that. So I've not gone into each individual study because it's not coming into the preview of this discussion. And they also found that there's better quality of life in protein restricted diet. And most of the RCT, when they actually looked at protein restriction, low protein diet alone, there was no significant decrease in the decline of GFR between LPD and usual protein intake in most of the trials by individually. But then when they try to sort of do meta-analysis involving trials of same caliber, they found out it is sort of tilting towards beneficial of having a low protein diet. The phosphate levels are decreased in few trials. And the diet, so now we are recommending a dietary restriction of 0.8 per gram per kilogram or 0.6 gram per kilogram. Now we need to make sure, does the patient actually take that kind of a dietary intake? So by analyzing what is the dietary intake they are actually taking, is it in tune with the recommendation? We need to find out what is the dietary intake. And they found out that the adherence was not maintained because you recommend a thing and the patient continues to not take that. And then probably that means to say that we cannot extrapolate it in real life scenario in which the adherence will be mattered, and that might skew our interpretations. And we need to find out whether the low protein diet is actually interfering with the nutritional status of the patient. And they didn't find any effect of this low protein diet on nutritional status, in which they try to find out multiple anthropometric measurements. They try to measure the serum albumin, the pre-albumin, and none of them were actually altered by the low protein diet. Blood pressure, they found out that diastolic blood pressure had decreased a bit in a patient who has got a low protein diet. There was a favorable lipid profile in the sense that there was decrease in the LDL and triglycerides in a low protein diet. And when they try to see what are the benefits in very low protein diet along with alpha keto analog, and let us try to understand what is this alpha keto analog supplement mean. Basically, it has 4 essential amino acids keto analog, that is leucine, isoleucine, phenylalanine, alanine. It's got on 1 hydroxy acid of methionine, and it has got 4 amino acids of tryptophan, histidine, and tyrosine and threonine. So basically, it sort of tries to give that extra mileage of an essential amino acids in the background of severe protein restriction in the form of a very low protein diet. And they found that in patients who have got a GFR of less than 20, in non-diabetic patients, a protein restriction of 0.28 to 0.43 gram per kilogram supplements are recommended. Pooled study showed that there is definite renal survival benefits with BLPD plus keto analog. Most studies showed a decline of GFR. So basically, as compared to LPD, the BLPD plus keto analog, most studies showed there was a decline in GFR, a decrease in the decline of GFR in patients who received BLPD plus keto analog. The phosphate levels were decreased, and they were able to maintain the dietary intake for a longer period of time without actually, so the adherence was good, without much change in the nutritional measurements in the form of albumin and anthropometric measurements. What the special points we need to be thinking is that this diet is something which has to be progressively installed with adequate amount of dietary counseling and maintenance of adequate adherence. So this is not something which can be done overnight and something which can be taken lightly, but requires a lot of effort and counseling and monitoring to bring out the real effect of the same. We should have a track on the energy take, because we know that every patient, based on the age, is around 35 kilocalorie per kilogram or 30 kilocalorie per kilogram. And when we protein restrict it, there is a chance that they will go into protein energy wasting. So we need to have a track on the energy intake and basically supplement the energy by other forms. Otherwise, they will go for protein energy wasting. And if at all a patient has got protein energy wasting due to some reason in the form of decreased intake, or because of an acute insult in the form of infection, or because of a catabolic state, it's important that the priority to be given for the correction of it rather than going for the typical conventional protein restricted diet. Because if we don't correct that protein energy wasting at that point of time, it might actually counterfire on us, and then patient will have increased mortality. So it is very important that when a patient has got a protein energy wasting, which we have figured it out, that is only possible when we do a close monitoring of the patient, and if it is found out, a priority has to be given for the correction of it. Next is that does it apply to children? Definitely not. And then that's what Dr. Darshan would probably elaborate on the same. And as far as children are concerned, these restrictions doesn't matter, and we are ideally supposed to give the recommended dietary allowance, because in them there is a chance that early protein allergy malnutrition would sort of set in. So now we found out what is the degree to which the protein has to be restricted. But does the source of the protein matter? Yes. The newer studies have shown the source of the protein also does matter. There is an increase in the animal's protein is associated with increased proteinuria. A high animal protein is associated with decrease in GFR, especially in patients with CKD. An animal protein can increase creatinine by increase in the muscle mass. So in a patient whom we are actually giving animal protein, there is a chance that the patient might actually have an increased creatinine because of an increase in muscle mass. So increase in creatinine using non-creatinine based estimated GFR would be a better option when we are trying to analyze between animal protein and plant protein. And also we found out that paracrosol sulfate and indoxyl sulfate are all involved in the pathogenesis, and there is a decreased production of these chemicals with respect to plant protein than animal protein. The plant protein also has high fiber, and this high fiber will result in the microbiota producing more of anti-inflammatory chemicals rather than pro-inflammatory chemicals, and hence can decrease the inflammatory milieu in a patient with CKD. It also is found that the plant-based protein have decreased phosphorus content, and hence it will have a favorable profile on the metabolic bone disease. And plant protein also decreases the acidosis, and this decrease in acidosis will result in decreased renal progression and mortality. So now what is a term called Plato Diet is there? What do you mean by Plato Diet? There's a plant-dominant low-protein diet for conservative management of chronic kidney disease. Here we try to give a low-protein diet along which is predominantly plant-based. So that is what multiple trials have been done in patients with low-protein diet, in which the dominated protein is plant more than the animal. So what are the disadvantages of Plato Diet? It's basically inadequate essential there might be essential amino acids which might be important, and that is inadequate in plant-based diet. The plant-based diet might have a high potassium load with resulting in hyperkalemia, and it can result in the risk of protein energy wasting, and there can be low palatability and adherence. So before I conclude, I think it's important that we know what is the recommended protein restriction for each group of people. And it's also important what are the red flag signs, whether the patient is already in a stable state without any inflammation, without much of protein energy wasting, where we can actually safely implement the protein restricted diet. And when we implement the protein restricted diet, we do adequate counseling and make sure the adherence is well maintained, and follow up the patient's anthropometric measurements as well as protein intake, probably by a 24-hour dietary recall, which we can probably do in OPD with a little more effort and with close monitoring, and try to increase the plant-based low-protein diet, which can gives us better results. Thank you so much for your patient listening.